Thank you, respected chairman and my dear colleagues. Today's particular topic is on antibiotic resistance breakers. It's a pretty basic topic today, being a entirely surgical conference. And this is the most important thing that we face today, because in the end, all comes out to be a lot of survival does come out to be based on antibiotic, whether the patient goes into neutropenia or post-surgical or developing any infections. We do have only a handful of antibiotics, and options are running out fast, and we are combining an antibiotic with a beta-lactamase inhibitor. And this particular antibiotic also uses something called an antibiotic resistance breaker, in which I'll elaborate. Particularly with respect to the global concern, now the largest amount of deaths we see is road traffic accidents, and apart from that, cardiovascular diseases. Cancer does take away 8 million people in a year. In the end, we do see that the antimicrobial resistance is also creeping up to about we can say 750,000. That is the estimated right now. And it is supposed to increase to nearly 10 million in 2050. Hence, that will be the largest cause of death in the group, irrespective of whatever be the background, whatever be the whether infection or road traffic accident or anything. Antibiotic resistance, particularly when we see carbapenem resistance, in neutropenic patients, we do see a mortality rate of as high as 60%, sometimes even as high as 80%. We are losing patients within hours of them presenting to the hospital. So as we see the carbapenem resistant trends in India, they do vary between various studies. And with Escherichia coli, it's about 40%. With Klebsiella, it varies between around 30% to about 72%. For Pseudomonas, it is 30%. And Acinetobacter, it is 69%. And they are the most common lot, the gram-negative cause in neutropenic patients. They primarily, many of them in neutropenic patients do reside in the gut. And from there, they translocate whenever there is any neutropenia, whenever there is any mucositis, any insult that occurs which breaches the gastric mucosa, the gastrointestinal mucosa, these do get into the bloodstream. And particularly important in the Asian scenario, because of rampant use of antibiotics, people are taking antibiotics even for smaller infection, just for a URI or a simple infection. People are, many patients are taking over-the-counter antibiotics. Although I think in our state, it has been reduced to a large extent where you do need a prescription. So the same with the third generation cephalosporins, the ones that we are commonly used to use. Now we are all using cephalosporin with a beta-lactamase inhibitor. They are nearly 80 to 90% resistance to the gram-negative bacilli. So the WHO pathology, the priority pathogen list for, I'm going to focus on India, is particularly in the Enterobacteriaceae, the Klebsiella and the Escherichia coli. Klebsiella having a very high mortality with carbapenem resistance, tigecycline resistant and colistin resistant. Many of the strains now are colistin intermediate, and pretty soon that will be resistant. So colistin is among the last line antibiotics. Of course, there are newer antibiotics like the beta-lactamase inhibitor like ceftazidime-avibactam, or even meropenem-varmobactam, which is about to come. But there are no other newer antibiotics that are being produced. So this is an article published in Lancet in 2022, which was showing an antimicrobial resistance, a health problem whose magnitude as large as major diseases, with a potentially higher danger, with an estimated nearly 5 million deaths with AMR in 2019 and 1.2 million deaths that are attributable actually to bacterial AMR. And lower respiratory tract accounted for about 1.5 million deaths, and making it the most burdensome infectious syndrome. So what is an antibiotic resistance breaker? Basically, we are using an antibiotic, an old antibiotic, and combining it with a resistance breaker and making it a new antibiotic. The basic beta-lactamase inhibitor, like for example, cefoperazone sulbactam, or the newer ceftazidime-avibactam is also a classical example. Now, how does the resistance act? I'll be brief on it. Mainly, it acts by 4 mechanisms. Firstly, the drug that has entered the cell is undergoing an efflux. Secondly, the drug that is outside is not allowed to come in. Thirdly, there is a breakdown of the drug by the enzymes. And fourthly, there is a target modification. Now, how does the ceftriaxone sulbactam EDTA act? It acts through, usually the ceftriaxone is an inhibitor of the synthesis, the cell wall. Sulbactam forms a protein complex with the beta lactamases. Beta lactamases actually those enzymes produced by bacteria which will destroy these beta lactam antibiotics like cephalosporin and penicillin. And EDTA, particularly target when combined to it with has multiple resistance mechanism, particularly in the indwelling catheters where biofilms are being formed. It breaks that and also increases the efflux. It decreases the efflux transporter mechanism. These are the two main actions by which this drug is acting. So primarily indicated for moderate to severe infections, including hospital-acquired, community-acquired infections, complicated urinary tract infection, including acute pyelonephritis, and lower respiratory tract infection, including community-acquired pneumonia. Now, this was an article published in Open Forum of Infectious Diseases and published by PGI Chandigarh, which was a phase 3 randomized control trial with 74 patients in the CSE arm and the 69 patients in the meropenem arm. Now, basically, when we look at the efficacy of antibiotics, we do the end of therapy, that is 5 to 14 days, that is one visit at the test of cure, that is that 8 to 12 days post this end of therapy, and a late follow-up 5 to 9 days post test of cure. So culture is taken at each of these intervals. And with this, it was found that the ceftriaxone sulbactam EDTA compared to meropenem had slightly increased, or maybe a 4 to 6% difference between the efficacy in terms of clinical cure, microbiological eradication at the test of cure. That was the FDA primary endpoint. And the EME primary endpoint of microbial eradication was also 94.6%, while it was 89.9% for meropenem. There was no statistical difference, but it was said to be it was said to conclude that the CSE is actually not inferior to meropenem. So hence, the idea behind it is that some of these antibiotics may be used as sparing agents. We can spare meropenem, we can spare colistin as a later line agents in these scenarios. Now, this is another study that was conducted in SGPGI Lucknow with 2,760 sample. Predominantly blood, respiratory, and pus contributed to mainly 90% of the sample. Found that the extended spectrum beta lactamase and the metallo-beta lactamase, these are the enzymes that are responsible for the bacterial resistance, were nearly present in more than half of the patient. And this drug was, supposed to be a colistin sparing drug. And as we can see, Aloris is the ceftriaxone sulbactam EDTA. Has higher sensitivity, that is nearly more than 90% susceptibility, and also which was equivalent to colistin compared to ertapenem, meropenem, and imipenem, which had nearly 20 to 30% sensitivity. This was with respect to ESBL, and also similarly was respected also with the metallo-beta proteinase, lactamases. And with respect to the NDM-OXA now in the microbiological sensitivity, in the wake of resistance, there are classes of enzymes, and NDM class B, and OXA comes as class D. All these classes of enzymes, against these also the Aloris and the colistin have shown to be more than 90% susceptible. Now, with this background in mind, we have a small collection of patients with our center. The number of patients were 13, the male were 8 and the female were 5. It's just an observational study, no part of a trial or anything. And the mean age was nearly 38.8 years. And the diagnosis was this, in which the ones that are highlighted in purple were actually non-neutropenic, the other ones were neutropenic. And the number of patients who were on ventilator were 2 and one was on NIV. The phase of chemotherapy, most of them were in the initial phases, nearly 75% in the cycle 1 to cycle 3 chemotherapy. The duration of neutropenia, most of the patients were less, in the neutropenic phase was less than 14 days. Consequently, we are not using it, particularly in the transplant scenario, where the duration of neutropenia must be much higher, sometimes even beyond 2 weeks also. Carbapenem resistance was found in 75% of the isolates, and septic shock was seen in nearly half of the patient. And subsequent culture negative status that we had checked at the end of 7th day and at the end of 14th day was 11 days. We are using double the dose for neutropenic patient, that is 3 gram 12th hourly, while 1.5 gram 12th hourly is the standard dose used for minimal infections. For ventilated associated pneumonia or complicated UTI, it may be more prudent to use 3 gram IV 12th hourly. And 2 patients had succumbed to the disease. And the 3 patients out of these had underwent bone marrow transplant successfully in our institute without the resurgence of the same infections. So with this, I conclude the talk, and the session is open to questions. This is a bone marrow transplant unit in Aster MIMS. So we have completed 120 transplants in the last 3 years. Thank you.
Thank you very much. I think great job, and keeping an eye on antibiotic abuse.
Resistance.
I think I will say abuse because a lot of people use just left and right, and I think nowadays selection is very important.
Yes, sir.
Thank you very much.
Thank you.